Welcome to Pharmacy Prep. This video is about the question alerts or high yield points on antipsychotic pathophysiology and structure activity and clinical pharmacology. So this video is mainly focused on some basics and also the very high yield points were most likely the questions that are can expect in the board exams. So this video can be very useful and effective for the students who are preparing for pharmacy board exams, medical board exams, or nursing exams, or any other exam that are expected to have psychotic or antipsychotic questions. So let's begin with some basics of pathophysiology of psychosis. So there are four dopaminergic pathways in the brain. So those dopaminergic pathways are associated with the schizophrenia or psychosis. So here, first one, I like to explain about the mesolimbic pathways. The mesolimbic pathways are projects from ventral tegmental area to nucleus accumbens. So these blue ones are basically is a mesolimbic pathways. So in these mesolimbic pathways, increase in dopamine activities. So increase in dopamine activity can lead to the positive symptoms of psychosis. What are those examples of positive symptoms? The positive symptoms include hallucinations. So hallucination could be visual hallucinations or seeing something that's not real, or auditory hallucination. One can hear some voices, etc., or delusions, or excessive paranoid, like all those, and several symptoms are associated with the positive symptoms. So in the high yield point here is the mesolimbic pathways increase in dopamine activity lead to the positive symptoms of psychosis. And then the next here, the second pathway is mesocortical pathways. The mesocortical pathways sound like a mesolimbic, but they're not exactly mesolimbic. So this, the green colored here. So these green colored pathways project from ventral tegmental area, VTA, to cortex. So cortex, frontal cortex. So, and the frontal node cortex. So here are those in the frontal node cortex that are prefrontal cortex and also ventromedial prefrontal cortex. So this project in this area of those dopamine. So here, mesocortical pathways, in these pathways, deficiency of dopamine. Here is, just keep in mind, that's a very high yield point. A lot of times understands that many students understand that increase in dopamine causes the psychosis. That is true, only that relevant to mesolimbic positive symptoms. However, in mesocortical cortex, and deficiency or decrease in dopamine activity can lead to the negative symptoms. Negative symptoms of psychosis. What are those examples of negative symptoms of psychosis? Like some of them are like social isolation. Someone is completely not socializing with someone, or locked up into the place, which not going outside at all, or not maintaining basic hygiene, or not doing daily activities, not taking shower for days and months, have no, generally negative symptoms means a person, normal person have it, and this patient doesn't have it. Whereas positive symptom means normal person doesn't have it, but this patient generally have it. So it's kind of opposite to each other, but those are coming from mesocortical pathways. Additionally, the mesocortical pathways also have other symptoms associated with these cognitive symptoms. Cognitive symptoms means like thinking, ability to execute functions, doing daily functions, or learning, memorizing. All those are part of those, or recognizing people. All those are part of the cognitive symptoms. So therefore, the high yield point here is, or question alert here is, Wherever there is a question, I generally mark as a Q, that is a high alert point, which is basically decrease in dopamine in mesocortical pathways can lead to the negative symptoms. And now, the third dopaminergic pathway is negrostatial pathway. This negrostratal pathway is a project from substantia nigra to stratum. So this pathway have no association to psychosis. However, most antipsychotic drugs, they do affect on this pathway, and they eventually, antipsychotic drugs they are dopamine inhibitors or antagonists of the dopamine. So eventually, most of the antipsychotic drugs, they do affect on these nigrostriatal pathways and eventually decrease the dopamine activity and eventually can lead to the side effects of those drugs. Among those side effects, commonly seen side effect that is associated with the substantia nigra deficiencies of dopamine is called a EPS side effect. EPS means extrapyramidal symptoms. It is a group of symptoms. Those are grouped into extrapyramidal symptoms, which is associated with the deficiency of dopamine in these pathways. Additionally, it also comes with tardive dyskinesia, which is associated with nigrostriatal pathway. So the high yield point here is the obviously most antipsychotic drugs, they are not selective to only this mesolimbic pathway, because the goal of antipsychotic drug is to lower dopamine activity into this into the mesolimbic pathway. But since the medications are non-selective, most of them, and eventually the one which is the older versions, older drugs, first generation antipsychotics, which is obviously has a higher chance of having adverse reaction or adverse side effects, which are cause the extrapyramidal symptoms and tardive dyskinesia. So that is the significance of nigrostriatal pathways in antipsychotic or psychotic drugs. So here, next to last one, the fourth pathway of dopaminergic associated is tuberoinfundibular pathways. And tuberoinfundibular pathway is a very interesting one. And also it is a very high yield point here is this is project from hypothalamus to pituitary gland. So here, this one, this is the pituitary gland and hypothalamus, the lower part of the brain. So the hypothalamus to pituitary gland projection is done by tuberoinfundibular, which is also containing dopamines. So what is the significant, what is the high alert point here? The question alert is, whenever you decrease the dopamine in hypothalamus, eventually increase the prolactin. So it's kind of inverse relation. Just remember, that's a very frequent questions on that one. So when all the drugs, obviously the antipsychotic drugs that decrease the dopamine, eventually they can increase the prolactin levels. So therefore, many drugs such as risperidone or other more drugs in the antipsychotic drugs, they do eventually increase prolactin. Increase in prolactin, also known as hyperprolactinemia, or also known as galactaria. So there often you hear those terms in the questions and answers, galactaria or a hyperprolactin or increase in prolactin level. That is because of decrease in dopamine activity in tuberoinfundibular pathways of the brain. And then additionally, one more high yield point here is that whenever there is a decrease in dopamine, also can lead to the decrease in FSH, follicular stimulating hormone from the pituitary gland. So when decrease in follicular stimulating hormone FSH can lead to the condition amenorrhea, so which is caused by deficiency of dopamine as well. So therefore, there are some drugs can be associated with amenorrhea side effects of those one. However, whenever there is a dopamine increases, eventually prolactin, which is exactly inverse relation, so therefore it decreases. So those are the high yield points that are expected into the exam. So here I like to mark as a Q where the questions can come in the exam. So here there is a 1Q. Wherever I mark as a Q, there is a likely potential questions. So there is a potential questions on negative symptoms. And also we will see as we go further negative symptoms, we will discuss later how those medications, the second generation medication, second generation antipsychotics helps in treating negative symptoms by increasing dopamine in mesocortical pathways, which happens by inhibition of 5-HT2. Basically, when you serotonin, which is a 5-HT2A, whenever you inhibit the 5-HT2A, the dopamine in mesocortical pathways increases, and eventually that helps to improve the negative symptoms. That is what we'll see in second generation antipsychotics. Second generation antipsychotic that include Clozapine, quetiapine, olanzapine, risperidone, aripiprazole, and haloperidol, ziprasidone, asenapine. There are several drugs we will see now in a minute. So all those drugs, those have an effect on 5-HT2 inhibition. So whenever you decrease the 5-HT2, it increases the dopamine in the mesocortical pathways, and that helps in improving negative symptoms. So other question alerts, I encourage here to memorize this point. Obviously, the EPS, extrapyramidal symptoms, we will see in the future in a few minutes about that. So, so those points also eventually decrease in substantia nigra, also lead to those EPS. Remember, this is the same place where nigrostriatal pathway deficiency of dopamine lead to the Parkinson disease, which is one of the symptom of EPS. However, just to give you a high alert here that tardive dyskinesia is not related to Parkinson disease. Tardive dyskinesia is mainly associated with the antipsychotic drugs. Whereas extrapyramidal symptom, one of the symptom in the EPS is a Parkinsonism, which is caused by a decrease in dopamine in the substantia nigra. And then additional high alert point or cues that you have to focus on is the relation of dopamine decrease to galactaria or hyperprolactinemia. So those are the 2 points that are important. Plus, additionally, role of amenorrhea due to the deficiency of dopamine, which is caused by deficiency of FSH or follicular stimulating hormone. So these are the question alerts that you should keep in mind from these points. So now let's look at the structure activities of antipsychotic drugs. Sorry, this looks so tiny fonts here, but I have to really give you a little bit more time here to really focus on. So I tried my best because the information is so much, so I couldn't cover on this one. But we do have very detailed notes in our pharmacy prep clinical pharmacology book. You will find these details. So here, let's begin with some structure activities of antipsychotic drugs. So mainly you can break down into 2 categories. One is called first generation and the second generation antipsychotics. So a lot of time first generation antipsychotics also known as typical antipsychotics, whereas second generation is called atypical antipsychotics. So among the first generation antipsychotics, there are pretty lots of drugs, lots of medications here. However, I just covered something where there are high yield points or high potential questions can come in the exam. So here I like to point out, especially I like to mark as a Q about the chlorpromazine. Chlorpromazine, it's a potential question possible. So in the chlorpromazine, the reason why I put a Q because chlorpromazine is a first generation antipsychotic, which is a type of, chemically it is type of aliphatic phenothiazines. So it has a side chain which is called aliphatic phenothiazine, like this one, are examples of aliphatic phenothiazines. So this is one of the oldest antipsychotic drug. However, chlorpromazine never been used for psychosis. Chlorpromazine are mainly used for nausea and vomiting, especially in chemotherapy-induced nausea, vomiting, or also it is a second-line choice for the treatment of pregnancy-induced nausea, vomiting, and other types of nausea, vomiting. That's the main use of chlorpromazine. So the reason why it is more effective for chlorpromazine, it is a non-selective, but it does affect on chemoreceptor trigger zone, which is a nausea vomiting center in the brain, and which is which consists of dopamine, histamine, and muscarinic receptors. So chlorpromazine inhibit those dopamine, histamine, and muscarinic receptors present on CTZ. So that is the main reason why helps to reduce the nausea, vomiting. However, it is a non-selective. It also can lead to the side effects such as extrapyramidal side effects. Those are very potential risk of these medication for long-term use patients. And then the second drug in this category, which is I like to focus on in the same phenothiazine aliphatic side chain group, is promethazine. Promethazine, which is a well-known medication for treatment of motion sickness and nausea, vomiting as well. So the reason why, because promethazine, although belongs to the similar structure and also it is a type of antipsychotic drug, but primarily this act on inhibit the H1 receptor, histaminic receptors. So it has more histaminic effect and very little or almost nothing dopamine effect. So it has never been used as antipsychotic drugs. So it is a very, very little or nothing. That's a being advantage of this drug used into the motion sickness, because it has a less effect on dopamine. So eventually that helps to have more effect. Sorry, it is more effect on histamine and less effect on dopamine. So therefore, have less effect on less side effects of EPS or Parkinsonism, whereas more antihistaminic effect, and that helps in treating motion sickness and nausea, vomiting. So that's the one thing very special about promethazine, which is a part of the phenothiazine aliphatic side chain class of drug. So with this one, next we have phenothiazine. There are several drugs in the phenothiazine class, but I just picked up something which has more potential for the exam and more likely questions can come from those points. So this is called phenothiazine piperazine side chain. What that means is this 2 nitrogen containing cyclohexane ring is called piperazine. So this piperazine side chain, which is very unique for this type of phenothiazines. And here, one more point here, I like to let you know that these are considered as high potency dopamine antagonist drugs. So they are categorized into high D2 inhibition. That means they are considered as a high D2, like fluphenazine, the best example, or also Chlorpromazine. They are good examples of high dopamine D2 inhibition or antagonism of D2. What is that? What happens being a D2 high antagonism effect? Being high D2 antagonism, the advantage is it does helps in treating psychotic symptoms. So therefore, all these drugs of phenothiazine, piperazine side chain class of drugs such as fluphenazine, perfenazine, whereas trifluoperazines, those are considered as high D2 inhibitors. So therefore, they're only used for psychosis, not used for nausea, vomiting, etc. So only one drug here is a intermediate potency, that is a perfenazine is an intermediate potency. So, well, what is the question alert here? What kind of question I'm expected? And what is the high yield point that is expected in the exam? So likely it is more likely you can expect to have about fluphenazine. Fluphenazine is a good example because it also comes into the long-acting injection preparations. So therefore, those are very potentially used medication for patients who have a difficulty to comply with daily medications. So therefore, that's the one question alert about fluphenazine. Fluphenazine is contain piperazine side chain ring, which is a type of phenothiazine first generation antipsychotic drug. So next we got here the another first generation is called thioxanthine. Thioxanthines are also high potency dopamine antagonists. Both there are two drugs here. One is a fluphenazole and clophenazole. Both of them are considered as a high D2 inhibitors. So in this case, what is exactly the difference between the thioxanthine compared to the phenothiazine? This is not a phenothiazine. The only difference here is there is no nitrogen here on this site. Whereas if you notice here, there's a nitrogen for this one. So this is only one, there is no nitrogen. So therefore it is considered as the different than the phenothiazines. And these two drugs in this class are considered as a high potency. Obviously, since they are high potency, they are mainly used for treating psychosis. So what is the question alert? So structure activity can be a potential question in this case. And also clophenazine also comes into the injections. And sustained release or slow release injections also available, which is given for long-term or patient who have a difficulty to comply with the daily dose medications. And also remember, these medications currently not that commonly used for psychosis, but there are still used in some countries where the new medications are expensive. So, however, for exam standpoints, the most important drug in this first generation or more potential drug that is the most commonly used drug in first generation is haloperidol. Haloperidol is the most commonly used drug. So in the haloperidol, basically, which is has a very high activity on D2 receptors, which is considered as a high potent D2 antagonist. And it is not belongs to any of the phenothiazine. These are chemically called butyrophenones. So therefore, some of the side effects or non-selectivity which happens with these phenothiazines doesn't exist with this one. So only concern with this one is since it is a considered as a high potency on D2 receptors, eventually one of the most major risk of adverse reaction of this one could be extrapyramidal side effects. So that is can be explained from the high potency of D2. So as a result of that, this is one of the reasons why it is less preferable. But haloperidol comes in injections and which can be administered in acute care settings for patients who have a delirium or agitation cases. It is used as an injection for quick action. So one advantage that you should know that could be potential for the exam about these drugs, sometimes it is also used for elderly patient, so seniors, elderly ones. So the being haloperidol used in elderly, sometimes it is because of the reason why it has a very weak effect on muscarinic receptors compared to other first generation or other second generation antipsychotic drugs. So second generation or generally have a higher muscarinic compared to haloperidol. So that's the reason why the anticholinergic side effects that comes with the inhibition or antagonism of muscarinic receptors are less common with haloperidol. So that's the one question alert I strongly recommend that you should focus on those cues. Where there is a cues, there is a potential for the question. So that's what you have to really refresh your knowledge and quickly review those points where there is a questions. Remember, I am just erasing those questions as we proceed, because just to keep your attention on that point. However, you have to roll back, rewind back your video to watch whenever you want to see what are the question alerts on those drugs. So with this first generation classification, so I always encourage students to, especially students who are writing pharmacy exams, to relate your drug to the chemical structures. That way it helps you to memorize them, their classification, because you should be able to get those in few seconds in the exam when you see the name of the drug. Say if you see right away chlorpromazine, you should get this phenothiazine structure in the mind, so that helps you to really relate to those group of drugs in this class of those phenothiazines. So same way, when you hear about haloperidol, it is not belongs to any of this. It's structurally different, which is a butyrphenones. So therefore that could be helps you to identify easily those classification of the drugs. So that's one of the way to really memorize the names of the drugs, so that way in exam right away you can capture imagination of the drug and then find the best answer. Because when you go to the exam, especially when you're doing a case scenario or multiple choice question exam, what really matters most is your time. So in fact, within a minute, you should be able to understand the question, drug, name, and relate to those problems. That helps to answer them. So, and also a lot of times students mix up with the drugs names to the drug. So mixing up is very common, one of these step in the preparation. So therefore, to avoid the mix up of the drug names, it is very important to relate to the something chemically that helps to retain in your mind. The next one is about the second generation antipsychotic drugs. So among the second generation antipsychotic drugs, now the new references are breaking down into various groups. So here I have divided into three groups in second generation. The first one is the older ones are multi-acting receptor antagonist, or you can say MARTA, MARTA type. That means, as the name itself tells you what exactly it means, multi-acting receptor antagonist. That means it is basically acting on multiple sites of the receptors. So therefore, they are considered as multi-acting receptors. So, so these are the medications in this category include Clozapine, olanzapine, quetiapine, and asenapine. So all those names easy to remember. They all end with the pains. So zapine, pine, and pine, apine. So there are many ways there are similarities in between those structures, because first of all they're acting on multiple receptor site, and eventually since they're acting on multiple receptor site, they do have a severe multiple sites receptor. I mean, they produce multiple site adverse reactions. So there are many complications with these medications as adverse reactions possible. So therefore, they are considered as a multi-acting receptor. But still, those are very popular drugs, very commonly used. So let's begin with the first one, which is called Clozapine. Clozapine is a very popular drug, most effective drugs of second generation drugs. However, this has a limitation in the use just because it has a serious, very rare but very serious side effect of agranulocytosis. So it causes severe neutropenia, and that severe neutropenia limit the use of this medication, because it does require weekly monitoring for first 6 months. Weekly monitoring lab tests for the blood test have to be done, blood work have to be done, which is called CBC, or specifically white blood count, WBC, have to be checked every week to make sure that patient is having no risk of agranulocytosis or severe neutropenia. So, however, this drug is reserved or used for resistant type of psychosis. That means people who could not respond with other medications, and this is the only one hope. And this is used for a long period of time. So, This is something very potential question in the exam. So the potential question about the clozapine is about the CBC or WBC. So that require weekly basis. First 6 months require, and then after that you have a longer time to monitor biweekly or longer to monitor the WBCs for clozapine. So one more interesting point about the clozapine and the site of actions, it has a very high effect on histaminic and muscarinic. So that means that can cause antihistaminic side effect, which is histaminic side effect here mainly relates to the weight gain. So this is one of the high weight gain drug among the second generation antipsychotic drugs. And since it acts on muscarinic, so it has also cholinergic side effect, anticholinergic side effects. And being a 5-HT2A antagonist, the advantage is these drugs also helps to lower are used for the treating negative symptom. It helps in improving negative symptom because 5-HT2 lowering helps in mesocortical pathways to increase the dopamine and helps in treating negative symptoms. So it has a less D2 activity compared to serotonin activities. So being the less D2 activities, the advantage of this one is this has less extrapyramidal symptoms or side effects compared to this one. However, clozapine is known for weight gain, agranulocytosis, and also other antihistaminic or sedative effects are possible and anticholinergic side effect. But one of the unique side effect of this one is a hypersalivation. About 30 to 40% side effect of clozapine is hypersalivation. That means excessive saliva is produced with this medication. So that cannot be explained from this muscarinic activity. So next one here is olanzapine. Olanzapine is one of the important drug which is very frequently questions in the exam. So why it is so important question in the exam? Because olanzapine is a very strong drug. However, a good thing is it doesn't have those agranulocytosis like clozapine. So it doesn't have those side effects. Instead, this also has a multi-receptor site action. So this is known for multiple adverse reactions such as weight gain, and especially it has a very high metabolic side effect. What does that means? Metabolic side effect. Whenever I say metabolic means it can be can lead to the blood glucose, can cause hyperglycemia, or can increase the lipid levels, cholesterol, and also weight gain. Those are the three things are related to metabolic. So it is especially diabetes or hyperglycemia. So highest drug in this category, highest diabetic drug, that is olanzapine. So therefore, if you have a question on what drug is most likely, like generally questions are given as a case scenario, and the patient have a multiple complications, patient already have a diabetes or have a pre-diabetic. So now if you start this medication, there is a chances that that person can have a higher increase in blood glucose levels. So therefore that can lead to the more side effects. So this is the best answer if you have drug that to avoid in patient who have a multiple metabolic conditions. Then other medication, I remember this structurally they're all similar, with small variations. So they are also called dibenzodiazepines, but there are small variation in each structure. So the third drug here is a quetiapine. Quetiapine is well-known drug as well in this category. And quetiapine, basically, it is known for high sedative effect. It is a high sedation. Sorry, there's a printing error here. There are some HM receptors, and there is a alpha receptors here, and there is a alpha receptors. So it has a alpha 1 inhibition. This is alpha 1, sorry. This is alpha 1. So this alpha 1 inhibition lead to the orthostatic hypertension. So therefore, whenever you're increasing the dose of quetiapine, gradually increase the dose to avoid any severe sedation or low blood pressure. The both of them can make patient dizzy and likely can make fainting. So therefore, these medication, quetiapine, known for this one. And also quetiapine also has another thing which is known for QT prolongation side effect, one of the high QT prolongation drug in this category. So this is a few important points for the quetiapine. So sedation and orthostatic hypertension, and obviously has less extrapyramidal side effect, and also it has a higher metabolic syndrome, which is diabetes, and cholesterol is much higher compared to other drugs. However, slightly less than olanzapine. Olanzapine is the best answer for this category. So there is another drug in this multi-acting receptor is asinapine. Asinapine is something which is a similar category drug as a multi. However, chemically it is structurally different. It is basically drug derived from tetracycline chemical structures. So these are asinapine also has more 5-HT2 antagonist, and it has an alpha 2 activity. This is alpha 2 activity. And so it can be used for both negative and positive symptom because it has a more D2 and also 5-HT2 antagonist. So now this is about the multi-receptor antagonist. So again, as I mentioned, the question alerts on clozapine about the, just to summarize, is about the white blood cells count monitoring, metabolic syndrome, olanzapine, sedative and orthostatic hypertension, and also these are the questions, potential questions possible from these multi-acting receptors. So now let's go to the serotonin dopamine antagonist type, second generation antagonist, antipsychotics. So name itself tells you that means they are predominantly, they act on serotonin and dopamine. Unlike this multi-receptor, they do have a multi-receptor activity, but they have a more significant effect on this one. So there are two drugs here. One is the risperidone and paliperidone. So what is the something very important here is risperidone, which is belongs to the chemical class called benzoxazole. Like this chemical ring is called benzoxazole ring. So in this one, there are two drugs here. One is a risperidone and paliperidone. Paliperidone is a metabolite of risperidone. So only difference is for paliperidone, at this point, there is a OH. That is only one difference. It is metabolized to this one. So therefore, they have very similar activities. But one thing it is important here is these have the risperidone is known for one point that you should know. Sorry, there are small printing errors here. There are 5-HT2 and also histaminic and also alpha 1. The question on the risperidone is potentially can come about the its effect on, it does lower dopamine, especially on tuberoindividular pathways. So by lowering tuberoindividular pathway means it increases the prolactin levels, or it is known for galactaria. It is known for galactaria, right? Galactaria means increase prolactin levels. So this drug is known for that purpose, and also it has the extrapyramidal symptoms, especially one of the extrapyramidal symptom unique for this because it does inhibit the dopamine. Akathisia is a common extrapyramidal symptom for this risperidone. So paliperidone has a little better profile compared to risperidone because it does avoid the one-step metabolic reaction. The biggest advantage is it has less drug interactions because paliperidone is already metabolized product, so it does not go through the liver metabolic reaction. Since it doesn't have any liver metabolism, it doesn't cause any type of drug interaction. So it is a less drug interaction compared to risperidone. That's the one of the biggest advantage of paliperidone. And additionally, we have benzoyl thiazoles, which is slightly different than isoxazole. There are two drugs in this class. One is a lorazepam and ziprasidone. So these are very unique drugs because they do have additionally 5-HT1A effect, and those 5-HT1A effect and also have a very little histaminic and muscarinic activity compared to the other multi-receptor drugs. So that's the biggest advantage of this lorazepam and ziprasidone. And also they do not have much of metabolic syndrome side effects such as weight gain, and also they have less common diabetes and also dyslipidemia as compared to this one. So this is something. Ziprasidone is a very important one. Ziprasidone, 1 point question alert you have to know is it has also high QT prolongation side effect. So it does QT prolongation side effect compared to the other ones. So it does QT prolong. So, and also these drugs have, these two of them also have a 5-HT1 agonist activity, and this 5-HT1 agonist helps in treating depression as well. So people who have a resistant type of depression, it is antipsychotic medications are added to that one. One of them can be lorazepam, has been studied for that purpose. So therefore, it does utilizes for depression with psychosis, or patient who have a bipolar disorders also it is used. So now the last class of second generation drug is called D2 partial agonists, which are very popular ones. And D2 means dopamine partial agonists. So far, what we have seen is all them are antagonists, right? We haven't seen anything of this D2 agonist. So this is here we have these two drugs that are D2 agonists. Therefore, I mark as a Q. There is a high yield question here. Question is alert is possible. That means question, especially aripiprazole. Aripiprazole, which is a partial D2 agonist and 5-HT1A agonist. So therefore, it can be very potentially beneficial for psychosis, depression, and bipolar disorders. And also has an antagonistic effect on 5-HT2A that helps in negative schizophrenic symptoms. An additional advantage is these selective D2 partial agonist drugs. They have a less metabolic syndrome. So if you have a question in case asking that it is a, what drug would you go for patient who have a multiple comorbidities like diabetes, high cholesterol, and psychosis, then your best answer can be aripiprazole. So aripiprazole is to go for answers. So that's the best answer you can choose. So those are the potential questions on these points. And then followed by this, here you have a brexpiprazole, which is also belongs to the same phenylpiperazine class. This is called phenylpiperazines. So this also have a very similar profile, which is a D2 agonist and also 5-HT1A agonist and antagonist after 5-HT2A. So those are the potential points. So you wonder, how come agonist helps in reducing this antipsychotic psychosis, right? That's a good question you can think of. Generally, you are increasing D2. That increasing means it can worsen the psychosis. However, there are theories, lots of theories about it. What it means is when you do partial agonist, basically it's a kind of partial agonist. So when these drugs are like a partial agonist in those dopaminergic mesolimbic pathways, basically the other dopamines are much more sensitive and active compared to this one. So as a result of that, eventually this works like a partial antagonist and agonistic mechanism. So this is a very unique drug, which is a aripiprazole and brexpiprazole. So to make it summarize here before I proceed to the next one, so risperidone is the big one that I think of. Hyperprolactinemia, and chemically it is called isoxazole ring. And then comes to the A next question alert about the lorazepam, which is a big one. Lorazepam has a very little muscarinic and H1 activities. And then comes to the ziprasidone. Ziprasidone is a high QT prolongation. That's another question possible. And more potential question is finally possible from aripiprazole, which is a good option for a patient who have multiple comorbidities. So these are the high yield points from the structure activities of antipsychotic drugs. So now the next one is from the antipsychotic drugs, the common side effects. So we have a next video coming up, which is the antipsychotic drugs, highs and lows, which is a part 2 video. And in that one, because this one video can be too long and can be too boring for the students, so therefore we have a split into 2 videos. The part 2 video has more comparison of antipsychotic drug side effects, especially whenever you think of antipsychotic drug side effect. These are the 5 type of side effect commonly seen that you have to be really thinking about. Sedation, like we discussed, that second generation drugs have a more antihistaminic and muscarinic activity. That's one of the reasons why antihistaminic effect causes the sedation. Like we have seen basically quetiapine. Quetiapine was a good example, which is low dosages quetiapine also used for treating insomnia in some cases. So because it can cause a lot of sedation effect. So, and also general counseling point is take at bedtime if it is sleepy in the daytime. So that could be a good potential points. And then comes to the anticholinergic side effects. Anticholinergic side effects are associated with muscarinic receptors, and especially the second generation have a more muscarinic receptor side effect compared to the first generation. And especially the haloperidol has a less muscarinic activity. That way is good for elderly patients. In some cases it is used. And of course, the first generation are known for very high extrapyramidal side effects. So in a few minutes, we will see what exactly include in the extrapyramidal, and also the multi-receptor drugs such as olanzapine, quetiapine, and clozapine are known for weight gain side effects. And also these drugs are known for, also same time they're known for metabolic side effects. So however, for details on the question alerts of this comparison of highs and lows of antipsychotic drugs, please do wait for part 2 video. There you will see more better details on the comparison of the each within the class of drugs. So next comes to the question alerts on extrapyramidal symptoms. There are the 4 symptoms combined called extrapyramidal symptoms. The first one here is called dystonia. Dystonia is a kind of sustained muscle spasm in the neck or trunk, or also the eye. Could be oculogyric crisis. That means the eyes ball can stick upwards a lot of times. So that is kind of dystonia. So the treatment is important here. Here you're using benzotropine. Benzotropine is a type of anticholinergic drug. So anticholinergic drugs are used for treating dystonia. That's important question alert. Or sometimes antihistaminic drug, diphenhydramine in acute cases, injection is used. So another question alert here from the extrapyramidal symptom is akathisia. Akathisia is in one word, if you have to say, it's restlessness or tapping or pacing. So therefore, the best management is to reduce the dose or change to the different drug which has a no akathisia side effect. Like second generation drugs also have known for akathisia, like risperidone, etc. So the treatment is potential question. So I mark as a Q for the treatment. Propranolol or beta blockers is used for treating akathisia. Remember, this propranolol also used in Parkinson's disease for patient to treat the tremors. So this is something like that. So this is used for lowering akathisia. Akathisia is like a person feel crawling out of their skin. So it is very, person can be very restless, or If you're counseling patient for a minute or 2 minute, patient may not able to sit still, can get up and sit again and walk around. So this kind of restlessness or pacing or taping, those are these symptoms are combined called akathisia. So remember, treatment is propranolol, which is a beta non-selective beta blocker. So here is a Parkinsonism is another side effect that is part of the extrapyramidal symptoms, which is, the mnemonic for Parkinsonism is very popular. One is a trap, tremor, rigidity, akathisia, akinesia, and postural instability. These are the um, mnemonic for their Parkinsonism. This is sometimes also known as pseudo-Parkinsonism, which is induced by the drug. Generally, as long as patient is taking medication, this symptom may remain. However, after stop taking medication, symptoms will go away, such as tremors, especially during the resting time, night times, or whenever rest, and rigidity, especially cogwheel rigidity, gait, imbalance, face can be masked. So this can be managed again by using anticholinergic drugs. So here, that's another question alerts. So what do you use for those treating patients who have a drug-induced Parkinsonism? Well, first thing is to stop medication or change to the different drug, and then go for treating with anticholinergic. So all these three symptoms of EPS are reversible symptoms. I mean, generally they stay as long as patient taking medications. And then once completely medication is off, then symptoms will go away. However, one symptom will not go away, that is tardive dyskinesia. Generally, tardive dyskinesia comes later, after 6 months to 1 year after, and it is an irreversible side effect which doesn't go away. So this is like a pill rolling or lip tongue smacking. Those are the good examples, symptoms of tardive dyskinesia. Excessive blinking, which is similar to nystagmus. Generally, the risk is higher for elderly patient. And then there is one medication as approved by FDA, which is a tetrabenazine. And this tetrabenazine is used in some cases. However, most cases, till recently, there was no medication for this one treating tardive dyskinesia. But we will see discussed in that one in upcoming uh, video about those details. So for now, these are the question alerts from EPS. So finally, I like to finish with this one about the neuroleptic malignant syndrome. Neuroleptic malignant syndrome comes due to the higher, like when you do reverse the dopamine's prolonged depression of the dopamine can result into neuroleptic malignant syndrome. So therefore, it is mainly specific, is a serious medical emergency which require referral to emergency if it has been diagnosed. It is muscle rigidity, the classical example, fever, like high fever is possible, and tachycardia. So what happens is if it is not treated immediately, then can lead to the rhabdomyolysis, like breakdown of the muscles, and that can lead to the renal problems as well. So therefore, it does require monitoring CK to see is there any risk of myopathies caused by rhabdomyolysis, or potassium levels can come higher, and since it can also affect on white blood cells and renal function tests. So those are required to monitor for this one. So neuroleptic malignant syndrome symptoms are potential for exam questions. And then also you have a treatment option is dantrolene. Dantrolene or dopamine agonist sometimes. So dantrolene is a good answer for treating neuroleptic malignant syndrome. Dantrolene is a calcium ion channel blockers. It does slow down those effect of the breakdown of the muscles that is caused by neuroleptic malignant syndrome. So therefore, dantrolene is used for the treating neuroleptic malignant syndrome. So finally, I thank you for your time. I appreciate watching this video and look forward to see you soon for the part 2 video of the psychosis, which has the highs and lows of antipsychotic drugs and the best and most and least of these antipsychotic drugs are there. Until then, I thank you, and please do sign up for our YouTube videos, or you can log into the Pharmacy Prep and follow the lectures, weekly lecture that happens here at Pharmacy Prep. Or if you have any questions, feel free to contact us our number, and also please feel free to text on this number, or you can email us. We'll be happy to help you. And thank you again.